Distinguished chairs Professor Hu Xichun and Professor Chen Yiding, and Professor Badia, and dear experts and dear colleagues. Good evening. We are already familiar with each other. I'm Xu Binghe with the Cancer Hospital Chinese Academy of Medical Sciences. It is a great pleasure because I have also participated in the NATALEE to be the leading PI. I'm very happy to be invited to be the honorary chair of this webinar. In the ASCO, we have already heard the announcement of the results of the NATALEE. You are already very familiar with the results and findings. And also compared with ET alone, the CDK4/6 inhibitors, ribol plus the ET in the adjuvant setting would also be superior to the monotherapy or ET alone, and also reach the primary endpoint in combination with the ribociclib. And that means we have new options for the patients. And also in the ongoing ESMO, we also noticed that the primary subgroup analysis and results of the NATALEE have been released again. And we hope that this released results will bring some new inspirations for our clinical practice and also will be able to be guided with the HR-positive HER2 early breast cancer treatment options. And next, we would love to give the floor to two chairs, Professor Hu Xichun with the Fudan University Shanghai Cancer Center, and also Dr. Chen Yiding, second affiliated to Hospital Zhejiang University School of Medicine, to deliver the opening. Dr. Hu Xichun is already familiar to you, and he's going to make the opening first, and he is really one of the top experts of the breast cancers and also in the breast oncology. He has got a lot of talents, and also he published a lot of the papers and related to the clinical research. Without further ado, I would love to invite Dr. Hu. Sure, distinguished academician Dr. Xu and distinguished Professor Chen Yiding, and dear colleagues, good evening. And I would love to say hello to Professor Badia there. We all know that in the world there are two major conferences. One is ASCO and the other is ESMO. And in this year's ASCO, we have already heard the results of the clinical trial of the NATALEE, and we're very excited about the announcements and results. And the patients probably are more excited than the physicians, especially for the nodal positive when the mass is bigger than 5 centimeters, and another stratification is greater stage 3, then you can use the ribociclib. And on top of those patients with the nodal positive, what about the nodal negative? High-risk patients, they are also very interested in their situations, and they are asking, can we use the ribociclib, for example, to treat my disease? And we were saying that we need to wait until the approval by the FDA in the US. We also hope that the clinical trials in this year's ESMO will also bring more results to us. And we are all ears and hope that the results will also bring the clinical practice changing situation. And I would love to hand the time to the other chair of this webinar, and this is Professor Chen Yiding, the second affiliated hospital, Zhejiang University School of Medicine. As we have already heard from Dr. Xu's introduction, he's already a very famous oncologist and the breast cancer, and also the professor in surgery. And welcome, Professor Chen. Thank you, Professor Hu, and Dr. Academician Mr. Xu, and also Professor Badi, and also their colleagues, and also the experts. It is a great timing for us to gather online during the ESMO with the PIs in China and all over the world, so that we can discuss the NATALEE clinical trial. Because after the ASCO's release, we are also expecting a lot of the good news, and also in different subscripts we can hear the results in ESMO, and also we are very happy to see and hear that. And also for the stage 2 and 0 patients in those subgroups, they even get the benefits as well. So with this good timing and opportunity, we're gathered with a lot of the colleagues and experts in the oncology to talk about the CDK4/6 inhibitors for the treatment of the early breast cancer in the adjuvant setting. And we also have got the simultaneous interpretation. I would love to give you the introduction about the experts and some of the logistics during our discussion. The first thing is that we have the simultaneous interpretation available. So either you speak in Chinese or English, either would do, because we have the interpretation either way. And also, if you need to raise the questions, you can also find the Q&A window. You can also ask questions to the panelists there. And probably we can see that a lot of the colleagues would love to hear English or Chinese. You can also choose the language by clicking the language interpretation, then choose Chinese if you want to listen to Chinese, and you can click English if you want to listen to English. And also for this kind of the interaction window, you can open it up with the Q&A window, and you can keep in the questions, and that means online they will be able to see that, because academician Dr. Xu and Professor Hu and many top experts and colleagues of the oncology in China are also gathered, so we can have discussions there. And these are some of the webinar tips or logistics. And next, I don't know whether Professor Badia has successfully joined us. Let's see. Probably while we're just checking, I will share with you the introduction of Professor Dr. Adia. Badia, I believe that you're already familiar with Professor Badia. You probably have heard his lectures. He's with the Massachusetts General Hospital, who is attending at the hospital, Harvard Medical School, Boston, as the director of breast cancer research program at the Massachusetts General Hospital Center for Breast Cancer. Dr. Badia is interested in advancing research to improve the outcomes with the breast cancer. Dr. Badia has also led the clinical development of the antibody drug conjugate sacituzumab govitecan, the first ADC approved for patients with metastatic triple-negative breast cancer. Dr. Badia has received several research awards, including Outstanding Award for Research Excellence at Mayo Clinic, Young Investigator Award from Moscow, and Douglas Family's Foundation Prize for Excellence in Oncology Researching at the Massachusetts General Hospital. Dr. Badia is the editor of Precision Medicine Clinic section of The Oncologist, the co-leader of the Molecular and Precision Tumor Board at MGH, and editorial board member of ASCO Molecular Oncology Tumor Board. Let's invite Professor Badia to share with us about the topic for the progress of the therapy of the ESMO HR positive and HER2 negative.
ESMO 2023 from Madrid.
Okay, thank you. Please.
Absolutely. Thank you for the invitation. It's a pleasure to be here today. I see familiar faces. Hello, Dr. Zhu. It's great to see everyone here. So I thought I'll focus on management of hormone receptor positive breast cancer with a focus on CDK4/6 inhibitors. At ESMO 2023, we saw updates on NATALEE trial that I presented. So I was asked by the team to present the NATALEE results that were presented at ESMO and also put things in perspective. So let me start with first my financial disclosures. These are my financial disclosures. Why is this important? Why are we talking about CDK4/6 inhibitors in early breast cancer? Patients with hormone receptor positive breast cancer have a high risk of disease recurrence. CDK4/6 inhibitors have demonstrated impressive efficacy in metastatic breast cancer. So the question is, can we utilize CDK4/6 inhibitors in early breast cancer to reduce risk of recurrence? And we know that in early breast cancer, the risk of recurrence does not stop at 5 years. It can continue beyond 5 years. So we first saw the results of Monarchy, which was presented at ESMO in the virtual plenary session about 2 years ago. This looked at abemaciclib plus endocrine therapy versus endocrine therapy for patients with high risk ER-positive breast cancer. How was high risk defined? High risk was defined by two features. First, patients with 4 or more positive nodes, and second, 1 to 3 positive nodes who had at least grade 3 disease or tumor size more than 5. So this was a really high risk population. In this setting, we saw improvement in disease-free survival with the addition of abemaciclib, first with the 2-year follow-up, and then with subsequent follow-up as well. And at ESMO, we saw additional follow-up up to 5 years. And the bottom line is the benefit with abemaciclib was maintained, if anything, increased over time. The next question then is overall survival. Even with overall survival, we saw a trend in favor of abemaciclib. And then finally, Ki-67. This has led to a lot of confusion, but consistently, we've seen the same observation, which is that Ki-67 is prognostic but not predictive, meaning that tumors that have a higher Ki-67, their prognosis is worse than patients who have lower Ki-67. But in terms of benefit with abemaciclib, it's seen both in patients with low Ki-67 as well as those with high Ki-67 tumors. So the next question now is ribociclib. Ribociclib is the other CDK4/6 inhibitor that has been evaluated in this setting. The first results were presented a few months ago at ASCO 2023 by Dr. Dennis Lehman. This was the NATALEE trial, which was different from monarchE for a couple of reasons. First, that this also included patients with medium risk disease, not just high risk disease like monarchE, but also medium risk patients with stage 2A and stage 2B. Second is patients received ribociclib for 3 years as compared to 2 years with abemaciclib in monarchE, and this was compared against non-steroidal AI. In terms of stats, the protocol had pre-specified interim efficacy analyses, the first at 350 events, and then the final at 500 events. So at ASCO 2023, we saw the 350 event, the next one, the 425 event results, which were based on the interim analyses, and the final analyses, which is 500 events, will be presented in future. In terms of baseline characteristics, they were well balanced between the two arms. It included patients with stage 2A as well as stage 3 disease. 60% of patients had stage 3 disease, 20% stage 2A, 20% stage 2B. In terms of overall result, the study met its primary endpoint. Ribociclib achieved highly significant IDFS benefit. The 3-year IDFS rate was 90% with ribociclib versus 87% with non-steroidal AI. This was based on a median follow-up of about 2.5 years. The IDMC concluded the study demonstrated superior statistically significant efficacy and clinical superior efficacy. The risk of invasive disease was reduced by 25% because the hazard ratio was 0.75. The dose of ribociclib used in this study was 400 milligrams. So the rate of neutropenia was lower as compared to what we see with 600 milligrams, and also the rate of QTc prolongation was lower. The other side effect that was seen was liver-related AEs, which was about 8% as compared to 0.1% with NSAI alone. So in terms of further update, I presented the subgroup analyses results from the NATALEE trial at ESMO 2023 yesterday. The bottom line is consistent IDFS benefit was seen across all clinically relevant subgroups, regardless of menopausal status, anatomic stage, nodal status, age, or Ki-67. So let's look at these results in detail. If you look at stage, both patients with stage 2 and stage 3 derive benefit with ribociclib. For patients with stage 2 in the control arm, IDFS rate was 91%, which improved to 94% with ribociclib. This corresponded to a hazard ratio of 0.76. For stage 3, again, improvement from 84 to 87%, hazard ratio of 0.74. So it confirms that ribociclib has benefit both in stage 2 and stage 3 disease. Similarly, if you look at lymph node positive versus negative, we see similar results. Benefit with ribociclib maintained. For patients with lymph node negative disease, the hazard ratio was 0.63, which is a significant hazard ratio. And those with lymph node positive disease as well, there was benefit with ribociclib. The other thing I want to mention here is the control arm. Look at the control arm for patients with lymph node negative disease. The 3-year IDFS rate was 89%. So these are still patients who have risk of recurrence, and that's why we need better therapies in this setting. How about menopausal status? Again, the benefit was maintained both in pre as well as post-menopausal setting. By age, benefit was maintained, less than 65, more than 65 as well, similar hazard ratios. And then finally, Ki67 in patients who had tumors, Ki67 less than 20% versus more than 20%. In both the setting, the benefit with ribociclib was maintained. So this is consistent with what was seen in other studies like Monarchy, that Ki67 is prognostic. Patients who have Ki67 that is high. So if you look at the control group, the 3-year IDFS rate in patients with Ki67 more than 20% was 84%, as compared to 90% in patients with low Ki67. So it's prognostic. If you have a tumor with high Ki67, you have worse disease-free survival as compared to tumors with low Ki67. The next question is it predictive? And the answer is no, because both in low Ki67 and high Ki67, we see benefit with ribociclib that is maintained. So Ki67 should not be used as a factor for selecting ribociclib in terms of the CDK4/6 inhibitor. So overall conclusions, the IDFS was maintained with ribociclib as NSAI, and this was consistent with the ITT population, suggesting that the benefit is not driven by any group. The IDFS benefit was observed with ribo plus NSAI versus NSAI alone, regardless of stage, nodal involvement, menopausal status, age, Ki67 score. Also, the control arm of NATALEE confirms that this population is at risk of recurrence, including patients with stage 2 disease, and that's why we need therapeutic strategies like escalation with ribociclib to reduce risk of recurrence. Overall, these results reinforce previously reported results that there is a significantly lower risk of recurrence with ribo NSAI compared to NSAI alone in a broad population of patients with stage 2 and stage 3 disease. So let's now put this in perspective and think about 3 things. First, strengths and limitations of these studies. Second, implications for clinical practice. And third, ribo versus abema. NATALEE had a couple of unique features. First, it included patients both with stage 2 and stage 3 disease. Second, the dose of ribociclib was 400 milligrams as opposed to 600 milligrams to improve tolerability while maintaining efficacy. And third, the treatment duration was 3 years. And the idea was that with 3 years, we'll prolong cell cycle arrest and drive more cells into irreversible senescence. And this is exactly what was seen. The risk of QTC prolongation, the risk of neutropenia was lower with 400 milligrams as compared to 600 milligrams. Even QTC prolongation was lower with 400 milligrams than 600 milligrams. In the adjuvant setting, safety is a key consideration. So that's why 400 milligram is a better choice. In terms of follow-up, the median follow-up at this time was 34 months. Number of patients discontinued because of disease progression. There were some who discontinued because of adverse events. When the results were presented at ASCO and even the ESMO update, 57% of patients had completed 2 years of ribo, 20% had completed 3 years of ribo. So only a minority of patients have completed 3 years of ribo. So what we are seeing predominantly is the effect of 2 years of ribociclib at this time. Now, it's interesting to note that 2 other studies were negative. Balbo was negative in the adjuvant setting in Penelope B, as well as in the Palace trial. In the Palace trial, which was a similar setting as the studies, adjuvant CDK4/6 inhibitor, the curves pretty much overlap. So why were these studies negative, and why were the other two studies positive? It could be differences in the type of CDK4/6 inhibitor. If we look at suppression of Ki67, if we look at the neoadjuvant study results, there do appear to be some differences. The other important thing is treatment discontinuation, which was pretty high in Palace trial. Patients will not derive benefit from a drug if they do not take the drug or if they hold the drug. In the neoadjuvant setting, we've seen if you hold the drug for 4 or 5 days, the Ki67 tends to increase. So it's very important to have continued suppression of the cell cycle. And that's why in the NATALEE trial, 3 years of ribociclib was used to drive cells into senescence, which would increase the cure rate. The other question comes, should we reintroduce CDK4/6 inhibitor again? So patients get 2 or 3 years of CDK4/6 inhibitor, but we know risk of recurrence does not stop. So should later on CDK4/6 inhibitors be reintroduced? It'll be impossible to do it in all patients, but maybe that's where ctDNA could be helpful. And there are ongoing studies looking at this question, where patients who've completed CDK4/6 inhibitor, they get monitored with ctDNA, and if they have detectable or rising ctDNA, at that time you'd reintroduce the CDK4/6 inhibitor, and the primary endpoint is ctDNA clearance. But there are several factors we have to consider with a study like this. What is the ctDNA assay to use? How long it would take to get the ctDNA results? If the ctDNA is rising, what's the mechanism that's driving that ctDNA rise? Because the therapy should be linked to that mechanism. And it's unclear, once ctDNA is present, whether we can cure the patient from the disease or whether we are just delaying metastatic disease. So these are questions that will be addressed in the ongoing ctDNA studies, the DARE, the LEADER, and the TRACK study. And then finally, how about the other question, which is ribo versus abema? If we look at the results are fairly similar between ribo and abemaciclib. Abemaciclib just has more mature follow-up. The safety profile is different. Ribociclib tends to cause more liver-related AEs and can cause small but known risk of QTc prolongation. With abemaciclib, it's diarrhea. That's the number one side effect. It can also cause venous thromboembolism and pulmonary embolism. So all of these factors need to be considered. We know that patients with ER-positive breast cancer have recurrence beyond 5 years. We've seen results with abemaciclib and now with ribociclib as well. And if that's approved, it'll be good to have options to select from. Abemaciclib for high-risk patients, ribociclib both for high-risk and medium risk, meaning patients with lymph node negative disease. And in the future, we need overall survival results, but also biomarkers to identify who would benefit the most from abema or ribo and how we can optimize the duration of these CDK4/6 inhibitors and also consider reintroduction of CDK4/6 inhibitors for the right patient. Thank you for your attention.
Thank you, Professor Badia. Thank you for your excellent presentation. It's very interesting in this game. We are more comfortable to make suggestion to our patients to recommend this. And I still wait for the FDA approval. But now we get into the discussion, question and answer session. And 在这个环节，okay, I can
here.
Okay, we have for the panelist, we have the Professor Fan Zhaoqing from Beijing Cancer Hospital, and Professor Gong Chang from Sun Yat-sen Memorial Hospital, and Professor Li Junjie from the Fudan University Shanghai Cancer Center, and Professor Wang Hao from Sichuan Cancer Hospital and Institute, and Professor Xu Ying, the first hospital from the first hospital of China Medical University. Now we have some predefined question. Then we could move to the free talk. So please show us the first question. Now, the first question is about according to the primary study point data of NATALEE study reported at this year ASCO, compared with the non-steroid aromatase alone, non-steroid aromatase inhibitor combined with ribociclib reduced the recurrence risk of IDFS by 25% in the overall population. And at ESMO, the updated IDFS showed the consistency among the different subgroups were presented. So what do you think are the highlights in these results? I think that Professor Fan, your comments or your questions about this. Professor Fan, can you hear me?
Yeah, thank you, Dr. Hu, and thank you for Dr. Badia wonderful presentation. 我想呢，我要这个为了更流畅的表达我的。
Here, I would like to more fluently to express my opinions. I will speak in Chinese.
那么就这个问题来说呢，当然。
Now, here to this question, I think we just see again the study of NATALEE with the latest updates in ESMO. The latest updates as well as the key subgroups analysis. Well, of course, in different subgroups, we see the ribociclib has played a very good role, better than the NSAI alone. But here I have a question here I'd like to ask. I have noticed that it includes the patients with N0 according for about 12%. And also for patients without chemotherapy, also 12%. So I do not know if these two populations, they are the same population, because in different subgroups, well, the N0, the absolute benefit is even greater than the N1, 2, and 3. So is that because these patients, they are chemo-free? So do you have compared with the subgroups with chemotherapy and without chemotherapy? And also, Dr. Badia, do you think that in the future, well, for these N0 patients, when using CDK4 and 6 inhibitors, would that be a substitute for the chemotherapy? So these are my two questions.
Professor Badia, you mute your phone.
Yeah, I didn't hear the question.
Oh, the question is about the adjuvant chemotherapy for the N0 patients, because the percentage of patients who receive the chemotherapy is only 12%, and also in the whole population,
That is correct.
The N0 patients only 12%. So how about the adjuvant chemotherapies in this clinical trial?
Yes. In general, in US and I guess globally as well, the use of chemotherapy is decreasing for patients with hormone receptor positive breast cancer. We've seen results from the responder study that patients with lymph node positive disease, if their oncotype DX score is lower intermediate, they don't need chemotherapy. And so essentially the use of chemotherapy is decreasing. Now, whether the benefit of ribociclib would be different in patients who get chemotherapy versus not, we've not seen the full data yet. But based on what we've seen so far from other studies, I do not expect that the benefit of ribociclib would be any different in patients who received chemotherapy versus not.
His second question is: can we replace the chemotherapy with ribociclib with other CDK4/6 inhibitor?
I think that's a very good question, and something that needs to be investigated in clinical trials. I think in the right setting, potentially ribociclib could replace chemotherapy. We have seen results from the neoadjuvant study. A couple of neoadjuvant studies comparing CDK4/6 inhibitor to chemo essentially have shown consistent results that CDK4/6 inhibitors are similar to chemotherapy in terms of PCR and other endpoints. So in the adjuvant setting, potentially would show similar results as well. And from a patient perspective, would be much less toxic not to give chemotherapy, but to use a targeted therapy. But we need a clinical trial to answer that question. It's a very important one.
So next expert is Professor Gong. Professor Gong Chang, please.
Sorry.
Okay.
Thank you for Dr. Bader's very wonderful talk. I think the updated data from NATALEE clinical trial confirm the NASA combined with ribociclib reduce recurrence of IDFS, and according to the subgroup analysis, still confirm the recurrence. The reduced recurrence was observed in all the patients, regardless of the stage, lymph node status, menopausal status, age, and Ki-67 index. And I have one question. I wonder whether the role of Ki-67 index have different role in the estrogen receptor positive, but in estrogen receptor positive patients, but with different preparation of estrogen receptor, such as some patients hormone receptor positive, but the estrogen receptor positive very low, such as less than 10%. And in this subgroup, the role of Ki-67 can even have the prognostic or maybe have predictive of CDK4/6 inhibitor in adjuvant setting. Thank you.
Yeah, I can address this, and if others want to chime in as well, by all means. I think we've seen consistent results that Ki-67 is prognostic but not predictive as far as the use of CDK4/6 inhibitor is concerned. And I think regardless of ER levels or whether the tumor is luminal A or B, Ki-67 is not that helpful for selection, at least of ribociclib. Now, there is the other question where patients with smaller tumors sometimes have a more aggressive biology. And that was the rationale of including cohort B in monarchy, where patients with smaller tumors who had, say, grade 2 disease, can we look at Ki-67 to identify the subgroup that's at higher risk of recurrence, because it is prognostic, and look at abemaciclib in that setting. And it did show benefit with abema. So that's why that's the third criteria that's used to identify high-risk patients. So for a patient who has a tumor size less than 5, does not have grade 3 disease, but has Ki-67 of more than 20%, that would be a patient I would consider abemaciclib, because that patient is at higher risk of recurrence.
Oh, thanks. The third expert is Professor Li Junjie. Professor Li, please.
Okay, thank you. So can I ask one small question at first? So maybe I missed the key points. The median follow-up for this year's data released is how long?
It's the same as ASCO. So the ESMO presentation, we didn't have additional follow-up or no new events. It was subgroup analyses from results that were presented at ASCO. So about 2.5 years of median follow-up.
Okay, thank you. So now I have a question because now we released about the 3 years IDFS rate. It seems that the recurrence rate is a little bit higher than we have expected. For my knowledge, for node-negative patients, maybe the annual recurrence rate is about 2% per year. And now we can see that the 3 years IDFS is around less than 90%. That means the every year's per year's annual recurrence rate is over 3 points. So any comments about that?
Yeah, absolutely. And I think, this 2 years is an approximate. In a clinical trial setting, is the clinical trial data. There'll always be some variation. It's not precisely 2%. There's always some variation. It depends on the context. It depends on the inclusion of the proportion of lymph node positive versus negative patient. And even patients with lymph node positive disease don't have a uniform risk of recurrence. So at the end of the day, those metrics are helpful for global decisions. But for a clinical trial, it's clinical trial data. And actually, to your point, emphasizes the needs for a randomized trial. That's why we cannot trust on single-arm studies, because with single-arm studies, you look at some historical comparison, which might not be accurate. So it just emphasizes why we need randomized trials.
Okay, thank you. Yeah,
Professor Badia. Yeah, maybe Professor Lee, you have mentioned that all the negative patients now. For this trial, the patients with not negative, but with the median risk of recurrence. So it's a little bit different.
Yeah. So my point of view is whether all these patients included in this clinical trial, even they are not negative, they still have a little bit high risk. So it's not all those what we call the node-negative luminal type breast cancer patients, because usually even the 5 years IDFS for node-negative is above 90%. And now we should compare whether all in the subgroups we need to add ribociclib. So that's my question.
Yeah. Great. So the next expert is Professor Wang Hao. Professor Wang, please.
好的，谢谢胡一生教授，也谢谢巴迪安教授的一个解释。
Thank you very much, Professor Badia and Professor Hu, for the explanation. I have already learned a lot. I noticed that for today's question in the NATALEE trial, what are the highlights? I think Professor Ban Zhaoqing mentioned it. I think I echo with him for the N0 patient. It is quite clear, even that is a better benefit. So I would love to ask one question, because for the stage 2, stage 3, they are consistent in the benefit. And Ki-67 is not a predictive factor, but prognostic factor. So while we think about the past results, such as the type of high-risk patients, the results are not quite satisfactory. And also for monarchy and a PANAS study, does that mean also not necessarily we need to use the CDK4/6 inhibitors, because the stage 2, stage 3 consistent, N0 better than N+, and for the other trials to be considered altogether, does not mean we don't need to select the patients who are high risk for the CDK4/6 inhibitors. Instead, we should look at some other predictive factors to think about using CDK. Thank you.
Professor Badia, catch the question?
Yeah, I didn't catch the question.
Okay, is there any reliable predictor factor to predict the effectiveness of CDK4/6 inhibitor in the adjuvant setting?
What is a predictive factor?
Yeah, predict the effectiveness of the CDK4/6 inhibitor.
At this time, we don't have any predictive factors to predict the benefit of a CDK4/6 inhibitor outside of ER. And that was consistently seen in the metastatic setting as well. and the benefit of these CDK4/6 inhibitors is maintained even in low ER levels. We didn't see this. We've not seen this yet in NATALEE, but we saw at ESMO 2023 the results from Monarchy, and they looked at ER levels, PR levels, and KST7 levels to look at impact on benefit with abemaciclib, and it was maintained regardless of ER, PR, or KST7 results. And I would expect similar results with ribociclib as well. So as long as a patient has ER positive tumor, that's sufficient in terms of a predictive biomarker for benefit with the CDK4/6 inhibitor.
Okay. So the last expert is Professor Xu. Professor Xu, please.
Thank you very much, Professor Hu. Badia. I believe that for this question, I would love to share with you my view, because for NATALEE trial, one of the highlights is obvious, because for some of those are about the intermediate risks, especially the second is about the ET, because in a Monarchy, there are some of the ET OFS is in combination with the tamoxifen or tamoxifen with the others. So with the control group, so that means that it should have the intensification, but that is weaker. But for NATALEE trial, they are using the NSAI. So that means it is the stronger type of the control groups, the ribo in combination with superior to the groups. So because of the control groups or CDK4/6 inhibitors would already bring better survival benefit. But of course, we already talked about the other strengths. And I have a question to ask Professor Bardia. Question to ask you. The first is, the Monarchy trial, the cohort 2 still immature, and this cohort have some patients the same with NATALEE. So what's your opinion of this difference? Only the drug, the abemaciclib, or the ribo?
Yeah. So for patients who have high-risk disease, if ribociclib is approved, we'll have two options, both abema and ribo. How are we going to select? I think is going to be the safety profile. The efficacy looks quite similar. So similar to the metastatic setting, ultimately it'll boil down to the safety profile, diarrhea, venous thromboembolism versus liver abnormalities. But it'll be good to have options. Say you start a patient on ribo who's having liver abnormalities, then you can switch to abema. And vice versa. You start with abema, patient having a lot of difficulties with diarrhea, you can switch to ribo. So it'll be good to have options.
Maybe some medium risk patients in NATALEE is the patients in Monarchy cohort 2 patients, right? But the cohort 2 still have no positive data, but the NATALEE have. So do you think maybe for some N0 or say 2 patients with not too much high risk, we still need some data to enforce the NATALEE data?
Yeah. So for patients with medium risk, abemaciclib was not evaluated in that setting. And even the KST7 in the abemaciclib Monarchy trial was for lymph node positive patients. So lymph node negative, it's only Monarchy. It's only a NATALEE with ribociclib. And if it's approved by the FDA in this setting, I would feel very comfortable using ribociclib in the medium risk population as well.
Okay, thank you. And thank you.
Thank you, Professor Xu. And now we move to the second question. Professor Chen, you are the moderator. Professor Chen, please.
Okay, thank you, Professor Gu, and thanks to Dr. Badia and everyone. We give a nice discussion. So we move to the question 2. In the subgroup data mentioned above, in addition to the efficacy of ribociclib, we still see some sample course, including patients with the node-negative and stage 2 disease with a risk of recurrence in the control group treated with NSAI alone. What do you think should be done to meet the treatment needs of these patients? So first, we invite Dr. Fan. Dr. Fan, do you give me some comments?
抱歉，我刚才没有听到你说的。
Oh, sorry, I didn't really hear your question.
没有听到你说的问题。
Sorry, I didn't hear your question.
Group node negative and stage 2 disease at the risk of recurrence in the control group treated with NSAI alone. So, what do you think should be done to meet the treatment needs of these node negative and the stage 2 patients?
就是如何治疗这个2期的。
Okay, so the question is about how to better treat the patients who have the N0 stage 2? Yes. I think that for this type of the patients, because we still have the option of the chemotherapy, so in the intensive therapy, either it's from the monarchy or NATALEE trial, the CDK4/6 inhibitors would still be an option. And also there is extension of the follow-up time. And if for CDK4/6 inhibitors will still be the standard of care, that is my view.
Thanks, Dr. Fan. So next we invite Dr. Gong.
好，我刚刚是接着这个话题啊，我刚刚特别是
Right, I would love to follow up on that, especially while I was listening. And I believe that Professor Bhatia mentioned one thing, because if that's the N0 stage 2 and they're positive, does that mean we need to use a ribociclib on them? Because I don't think not all of them can use a ribociclib, but we also need to consider high risk and toxicity. So I would love to ask about the N0 stage 2 disease, because they have some of the high risks. Also, younger KI 67 is a high stage 3. If the patients are using the drug, the side effects would be high. How do we evaluate the risks and benefits of that patient, especially when the AE is quite severe? How do we choose? I would love to ask Professor Bhatia, because if we add some new agent on top of that, when the side effects would be hard to control, how do we evaluate whether we use this or not? Thank you.
So, Dr. Bhatia.
Yeah, I can provide my perspective as well. I fully agree that even patients with stage 2 disease are at risk of recurrence. And that's the point I was trying to make in my presentation as well, that the 3-year IDFS was 89% in this population, and that's only going to get worse with time. So for this patient population, also we need better therapies. And one option could be escalation to ribociclib. It should be noted in NATALEE, it's not like everyone with stage 2A was included. Patients with stage 2A needed to have some additional risk factors based on oncotype DX or mammoprint or grade 3 disease. So for the right stage 2 patient, treatment with ribociclib could be an option.
I
have another question to follow up on. So probably I would love to ask the question for the AEs. The word is used as a tolerable. Also, we have the word manageable, acceptable. So for the 3 different levels for the clinicians, what are the differences? Professor Bhatia, thank you. What's the difference of the acceptable, manageable? Did you hear the question?
Yeah, I couldn't. It was in Chinese. I couldn't hear the question. So if Tim could mention the question, I'm happy to answer.
Or yes, I want to know the difference between manageable, tolerable, 还有 acceptable other advanced.
我
觉得您可以将我的讲的那个3个的那个英文来给他解释一下，因为
I think that probably you can explain the 3 words because I would love to ask this question. The clinicians actually have a lot of the confusion on it because we believe there are 3 different words when we try to manage the patients. So Professor Bhatia, can you hear the interpreter? Now, this is the sound check from interpreter. So Professor Bhatia, you cannot hear the interpreter?
Okay.
I will try to answer that question. Because it is completely the feel by the physicians, and the first is about the adjuvant setting for the breast cancer, especially for the advanced patients who will use the ribociclib to treat the advanced breast cancer in Chinese as the bridge trial. Professor Shao is the lead, and I am with the IPC chair. We have the patients with the 600 milligrams. In the advanced stage, most of them are safe, especially in China. One thing is very different. We need to look at their QT prolongation. And we noticed that premenopausal patients, QT prolongation would be more in terms of the number of events if we pay attention and watch that. Ribociclib is not a chemo agent. So that means whether we can use a tolerable, manageable, acceptable to describe it, I think manageable might be more appropriate.
So I don't know if I just answer this question. Oh, thank you because I just I'm confused about these terms, the manageable, the tolerable, and acceptable. Okay, thank you for your explanation. Thank you. And of course, this explanation would be more rationale. So next, please welcome Dr. Lee. Okay, thank you. And so to this question, I think I have some of my own viewpoints. Well, when we say N0, well, relatively it is a low risk population. But let's see all the key subgroups about all the forest map of the IDFS. Well, for these all the subgroups for these and just HR is on the level of 0.75, but only for the N0 there is a 0.63. But for the little amounts of events, so there would be severe bias. And for the N0 patients, well, in experimental, in patients 200 patients and 16 events, and in the control only 18 events. So for the N0 population, well, for the number of the events itself, it is relatively low. So there would be a great bias of the results and of the trends. So including other subgroups, I still remember that, well, not say that the N0 population, well, it will be more beneficial to use ribociclib, but I think that with the delay of the time, but prolongation of the time, the HR would finally come to the level of 0.75. So to this end, well, for clinical practices for patients do not have such high risk of recurrence, we still consider the general risk for the recurrences. We see the multi-gene test and about the volume of the tumor and also the different stratifications, different types of the histological types. So in this population, we do not say that for its indexes, for these parameters, they would be more sensitive to ribociclib, but for these intrinsic pathological characters, they would indicate that there would be higher risk for the recurrence for this population. So if we still want to reduce the 25% level of the recurrence level, so we just have the pre-assumed level of recurrence of 2 to 2.5% per year. So then the IDFS, the absolute benefit would be 3 to 5%. So I think the conclusion will still work. And also as about the tolerance mentioned by Professor Gong, I still think that for this endocrine therapy, this endocrine adjuvant therapy, it is not a one-time sale. So when we see there is a risk for recurrence, we would recommend the patients to use. But the patient, if the patient is not tolerant, or if there would be in advance delay, we do not still insist on the 3 years of the use of the medication. And also we should mention that when we have the median follow-up of 2.5 years, there are still patients that do not complete the 3 years of the medication usage, but we still got the final results. So in clinical practices, the patients, they reach the 2 years, reach the 2.5 years, but it is still beneficial to their prognosis, not to be long enough to 3 years. It is still beneficial. Okay, thank you. Thank you, Professor Lee. And also the moderator told us because Dr. Badia did not choose the English channel, so we would speak in Chinese and let the interpreters to do the translation. So next, please welcome Dr. Wang Hao to your comments about the risk of the N0 and N1 and 2, the populations. Okay, Dr. Wang Hao, please. Okay, thank you. So thank you for all these and about the clinical practices, about using how these medications. You have also explained our questions. We have a similar comments with all of you. I think for these injuries with the benefits, there is this risk. And also there is the risk for the potential need for the therapies. And also for the N0 and stage 2 patients, it is not possible that all the patients will use it, especially in the inclusion for the clinical trials, we can consider it. But when we study that, when Professor Li Junjie said about the management of the patients, I am also concerning about this question. From my clinical practices, I will also pay attention to about the liver function disorders brought by ribociclib. And I'm also interested in this point about the 400 milligram will not just decrease the adverse events related to the liver to a very large extent. So just we have seen in the previous slides for the neutropenia, there is a decrease, and also for the QT prolongation, there is decrease. But for the liver-related adverse events, well, here 400 milligram does not have such great degree of decrease. So here I am also paying attention to this kind of adverse events. So to this point or population, well, I would choose the ribociclib, its usage. And also I would like to thank Dr. Li Junjie for your specific explanation about your conception of how to manage the patients. Thank you. Okay, thank you, Dr. Wang Hao, for your sharing. And so last, please welcome Professor Xu Yingying to talk about how to meet the needs for the patients. To how to treat the patients. Okay, thank you. And also for the previous panelists, they have a talk in an all-around way. And also to my own personal view, I think just as mentioned by Professor Bardia for MONARCH-E, well, for the high-risk patients, no matter it's MONARCH-E or NATALEE, they complement each other. For the high-risk patients, combined therapy of together with NSCI, they will benefit. But for the N0 and stage 2 patients, well, in the situation of high risk, I think for the MONARCH-E, compared to MONARCH-E or NATALEE, they will compare both high risk and low risk. So here for this part of the patients, do we have more the data from the real world experiences to the N0 population or stage 2 populations? Then what population will benefit? And also to this point for the Professor Badia,
它也不是所有的这种 N0 的或者27的这部分患者都会选择，也会综合的评估他的一个疾病风险。所以我特别希望看到这部分患者当中，他的一个入组人群的特征，以利于我们在选择的时候更有倾向。而且对于某些患者，我想还会有一些真实世界的这个数据进一步的来证实，的确呢，对于这些中风险的某些患者，我们采用一个 CDK4/6的一个强化治疗会更为获益。好，谢谢。
好的，谢谢徐颖教授的分享。其实因为在 N027这样的一些亚组里面的话呢，我们看到了单单使用这种非载体癌的一些复发的风险。但是如果让我们去没有任何差别去使用这样 CDK4 的强化的话呢，我们可能还是要去进行一些比较个性化的管理。就像刚才白迪亚教授也提到了，制造这些我们的所谓的组织液分级3级啊，包括 MMP 跟我们的这个21基因的一些高风险这些人群的话呢，可能有更多的一些需求。但这里面其实大家更多提到了，作为一个辅助强化来讲，我们怎么样去进行管理这些病人还是非常重要的。所以感谢这个环节我们所有的这个讨论嘉宾分享了对这些有需求的病人我们怎样去进行管理，包括怎么样去进行使用的这么一个非常精彩的观点。也再次感谢这个巴蒂尔教授的话呢，能够一直守候在我们的这一个线上，跟我们共同参与讨论。那最后的话呢，由于时间关系，我就把总结环节交给我们胡金教授和徐冰和院士，有请我们胡金教授给我们简单总结一下。 还是徐院士总结？
So Professor Xu would love you to actually give us a summary. Yes, so Professor Xu is still there. And especially we would love to thank everyone for the fantastic report, especially to go through the NATALEE and also some of the results that's being announced and released in the ESMO and ASCO ribociclib. We know that even though the adjuvant setting is not really mentioned, but actually they've been already used because it's being approved for the advanced stages. So I believe that in the future they can also be used for the HR positive or HER2 negative. The adjuvant setting as well for the breast cancer, especially compared with the CDK4/6 inhibitors, not only in the high risk population, but also in some of the stage 2 medium risk patients. They also have the clinical benefit, so the indications might be wider. And also in the clinical setting, we might get to the approval, and then in the clinical practice, we can also use that and get our experiences. And that means with the longer and extended follow-up, we can also see the results of the OS. And that means that there is also the trend, and we also hope that IDFS and the OS can also improve as we have seen from the results, and then they can benefit the Chinese population. Thank you very much. Thank everyone, and Professor Hu. Thank you, Dr. Xu. That's definitely a good direction. In general, I would love to say that for any adjuvant study for the breast cancer, it's really about the prophylaxis. And also that means if there are AEs, we can also stop it. But that means we can have the opportunity for the adjuvant opportunity. But for the Ki-67, that means when the score is higher, either it is the abemaciclib or ribociclib, but they have not addressed an issue where the patients would have the high Ki-67. That means it does not have any relations to do with that. And that means that when the Ki is really high, for the luminal type, we still need to consider the chemotherapy. That is the 2 points. Okay, Dr. Xu, we're about the time. Thank you.
我不说了，我刚才已经说过了，谢谢徐院士，谢谢蒲教授。
So thank you, Academician Xu. Thank you all for participating in the conference today. Thank you.